It's wonderful to see so many people here today, and we'll be talking more and more about AU 2030. AU 2030 is a broad concept that's cut across all our schools and colleges and library to look at ways to link faculty around large-scale questions, encourage faculty to work together across different disciplinary or school boundaries, and to respond in a more systematic and substantial way to the great issues of our time. Now, we've been feeding faculty lines to the various units over several years. There are initiatives that are further along than others in terms of the AU 2030 spirit. And I should say that AU 2030 is selected because that is well enough into the future that a junior faculty member would be, by that time, a more senior faculty member in their field and will be contributing in significant ways. And second is that the students who will be freshmen in 2030 were born last year, and we know the demographics of that population. And it's very different than the student population of today. It is far more diverse, far more, in terms of the population, Hispanic in terms of background, actually less white, and less African American in terms of that class of 2030. So we need to think today about the kinds of areas of research and the kinds of work and the kinds of institution we're going to be in 2030, because it takes us a long time to mature the faculty who will be here at that point. So we need to think creatively about that future. And one of the areas that was evident when I arrived was the broadest area of health, that here in this nation, but certainly around the world, considerable discussion has taken place and will continue to take place about health care and how we provide it, the costs associated with it, and the approaches, which is on one hand a more clinical approach, on the other hand a more systematic policy-related approach, which I want to talk about briefly today before we get into the program, which is really the broadest area of public health. And I think public health is a concept, a way of approaching health problems that fits very, very nicely into American University and the way we approach problems. And I'm going to take a few minutes just to simply tell you a fascinating story that really symbolizes the importance of this field, and that it's a classic story, and some of you may be familiar with it, called The Pump on Broad Street. And the story goes, it's not a story, it's a true story, that in between 1831 and 1854, tens of thousands of English citizens died of cholera. And cholera at that time was an unknown disease as to its cause, and the wisest minds at the time talked about it as a miasma in the air, and that there was no sense of sanitation as we know it today, and that there was, without running water, there was customarily a town well to obtain your water for cooking and washing. In fact, a diaper would be washed out in this well area. The term cesspools was used not as a pejorative term, but a cesspool was where you would wash out the clothes, you do your cooking, clean your cooking utensils, and so sewage was really dumped directly into the Thames, and cesspools were near the drinking wells. In August of 1854, there was a tremendous outbreak of cholera, and a local doctor, his name was John Snow, began to investigate. And within 250 yards of the intersection of Cambridge Street and Broad Street, hence the story of the Pump on Broad Street, there were over 500 fatal attacks of cholera over a 10-day period. So John Snow suspected that the water pump on Broad Street was potentially the source of this problem. So he used hospital and public records and developed a geographic grid to track those who had access to the pump and linking that to the cases of people affected with cholera that lived near the pump and used that pump for their daily activities. He took that research, as a good researcher should, and you who are faculty and students present your data to those town officials, and unfortunately they were enormously skeptical of such an analysis of why cholera was existing in their area. And so Snow, rather than forming a committee to further study the problem, to go to pharmaceuticals for some new creative answer, hiring more doctors to treat patients or nurses, he argued with the town leaders and to take the handle off the pump. And although reluctant, finally the officials took the handle off that pump, and you know that cholera immediately stopped. So he's widely regarded as the father of epidemiology, and this story of the pump on Broad Street illustrates the importance of public health. It's a different way of thinking that looks at more systematic approaches of how we can translate research and data into impact on society. And so as part of AU 2030, public health was identified as an area where we could look at interdisciplinary research that crossed the traditional divisions, departments, and schools, and we have invested in it. Kim Blankenship, who is the head of our Center of Health, Risk, and Society, was a key cornerstone to that effort upon her hiring. And as we continued to build this area, just this year alone, we added 4 more faculty in the Broad area. We hired Ardal Tekin in School of Public Affairs, who is a health economist, Nicole Angadi in sociology, Christina Krona in math and statistics, and Kathleen Holton in Seth were added. And today you're going to have more information about Dan ESSER in SIS, SONYA GRIER in COGOD, ANASTASIA Snelling in Seth and CAS, and of course Kim Blankenship. I should mention that if you're interested in more besides this talk today, Kim will be part of a panel about AU 2030 at the faculty retreat. And we are, for faculty, having a research proposal competition of which you need to work with a colleague on that, and that you would be eligible for a $5,000 research prize at the retreat itself. With that as the introduction of why public health is such an important subject for this institution, I want to bring back the University librarian, Nancy Davenport. Thank you.
And the library is delighted to host all of these reporting out sessions on research in progress. It's part of what makes this a rich and vibrant place. Some of you I know are freshmen, is that correct? May I have a couple hands here? Who are new students in the 3-year program on public health. Some of you I think are faculty members. And some of you are graduate students, I betcha. Isn't this perfect? This is exactly why you all come to this university in your various roles, to be able to engage with each other on exciting topics and working at the edge of research. And for the freshmen, this is why you picked AU. We're glad that we're here. Let me introduce our speakers, and I'm not going to read their full bios, but you can find them on the website for the university within their respective schools. But I do want you to get a sampling of the kinds of work they do, the kinds of grants they get, and the places where they publish. So you'll hear a little bit about each one of them, and feel free to as you talk about yourselves and your work, enrich it if I've left out something that you particularly like. We've also asked our speakers to speak briefly about the topic and leave time for engagement. And particularly with so many other faculty members in the room, I'm sure that we are ripe for having some exchanges back and forth. I'm going to start with Kim. Kim Blankenship is professor and chair in the Department of Sociology, and as the provost said, she is the director of the Center on Health, Risk, and Society. She's previously served on the faculty of sociology at Duke University and at the Duke Global Health Institute, and on the faculty at Yale, where she was also the associate director of the Center for Interdisciplinary Research on AIDS. She has received funding from NIDA, the National, I should have looked up all these acronyms. I'm going to skip CDC, I know, the Center for Disease Control, as well as the Bill and Melinda Gates Foundation. Her current research includes looking at mixed methods of study on the implementation and impact of community mobilization interventions for HIV prevention in female sex workers in India, and a mixed method longitudinal study of the impact of criminal justice involvement on HIV-related risk of reentrants and their sexual partners and its association with racial disparities. Daniel Esser. Daniel Esser investigates aid effectiveness in the control of local, national, and global development policies and programs. He focuses on 3 interrelated areas: local, governance in the context of armed conflict; local, particularly in his definition, includes urban; global health, agenda setting and resource allocation; and third, the discourses as frames for global development and policies. He has conducted his field research in Afghanistan, Pakistan, Sierra Leone, and most recently in Mexico. He has received grants from Canada's International Development Research Centre, the British Economic and Social Research Council, the Mellon MIT program on non-governmental organizations and forced migration, and the German National Academic Foundation and the German Academic Exchange Service. Sonya GRIER. Sonya GRIER is an associate professor of marketing and our Koch School of Business. She conducts interdisciplinary research on topics related to the societal impact of targeted marketing efforts, both commercial and social, and the multicultural marketing using a diversity of methodological research. Her current work investigates the relationship between marketing activities and consumer health, with a focus on obesity prevention among high-risk groups. She has published her research in leading marketing, public health, health policy, and psychology journals. She also currently serves on the editorial board for the Journal of Public Policy and Marketing, as the Director of Food Marketing Research for the African American Collaborative Obesity Research Network, and is a member of the Institute of Medicine Food Forum. Stacy Selling. Stacy is a professor and associate dean in the School of Education, Teaching and Health here at AU. She has been a member of the Academy of Nutrition and Dietetics as a registered dietitian for over 30 years and as a fellow in the American College of Nutrition. Her recent book, The Introduction to Health Promotion, has been released in 2014 through Josie Batch, publisher. Her research focuses on methods of behavior change in nutrition education to manage risk factors related to chronic disease. Specifically, her research focuses on using the school environment to improve the health of children. Dr. Snelling regularly presents her research at national and international conferences. Her research is published in many highly regarded journals focusing on nutrition, health promotion, and school health. She's appeared on C-SPAN to discuss food labeling regulation, and her opinions and expertise have appeared in such media outlets as Education Week, The Washington Post, U.S. News and World Report, and Fox Business News. So we come at this from a variety of disciplines and a variety of research methods. It's going to be lively. And Kim, I believe you're starting.
Are the slides on here?
Yeah. Our desktop, she said.
Okay, so we're supposed to talk about approaches to public health at AU, and I'm going to talk about a sociological approach to public health, which probably comes as no surprise as the approach to public health that I take, or really a sociological approach to health more generally. And what, in my view, broadly speaking, a sociological approach to health involves is understanding basically the social nature of health. So what does that mean? That, even things like the definition of what is health, what are our health priorities, What is health research? How do we go about doing health research? What do we take as evidence of impact? These aren't just things that are kind of automatically everybody knows. These are things that occur and develop in a particular social context, and those things can change over time. And the factors that affect that change and what they are social in nature. It also means that who is impacted, who is most vulnerable to what types of health outcomes, what groups are most vulnerable to what types of outcomes is also a social issue. And so if we look at something like distribution of disease across region or across like gender or race, we can't just think of those things as demographic factors or geographic factors. Those are social concepts, and they have social meaning. They're created and reproduced by social processes, and we have to understand how in that process health outcomes are also produced. It also means that the consequences of being healthy or sick or getting some type of disease are socially are a social phenomenon. Some people, whether you live longer, whether you die right away, what the quality of your life is partially at least a social phenomenon, a result of social structures and institutions and processes and so forth. And that the strategies that we use for promoting health or for promoting public health also must, at minimum, reflect some understanding of the social nature of health, if not ideally actually intervene in ways that change some of those social processes, contextual factors that are shaping health. And that's really where, in the field of public health, I guess I'm probably most well known for my contributions to the field that's thought of, or the interventions that are called structural interventions. That is, types of interventions that are targeted to changing social contexts in which health is produced or in which health is reproduced, as opposed to, say, changing individual behaviors per se, or more biomedical kinds of interventions. It's really focusing on interventions like policy changes or contextual changes that relate to health. So we were asked to talk about some of our key findings and some of our research. So Nancy indicated some of my research. I'm just going to talk about two key research projects very briefly. One of these is called Project Parivartan, which is funded by the Bill and Melinda Gates Foundation. And it's a project which is looking at the social dimensions of HIV risk among female sex workers in India, as well as analyzing the implementation and impact of an intervention that's been funded by the Gates Foundation that's called a community mobilization intervention, which is a particular type of structural intervention to address risk and HIV-related risk in female sex workers. And the second project is a project that's called Structures, Health, and Risk among probationers and their partners. I don't know, structures, health, risk, reentrants, probationers, and partners. And this is not funded by NIDA, which stands for the National Institute on Drug Abuse, which is part of NIH. And it's looking at the impact of the mass incarceration and re-entry process, that sort of cycle between prison and jail, sometimes referred to as coercive mobility, that results in large part from our drug policy in the United States, and to what extent is this coercive mobility associated with race disparities in HIV/AIDS, which are extraordinary in the United States. Both projects are large-scale projects, collaborative across disciplines, departments, nations, one is across nations, one is in multi-year and multi-methods research. So in terms of some major findings from the research, with respect to the vulnerability, various social dimensions of vulnerability of female sex workers. Female sex workers, and this comes from various publications that we've put out in analyses from our project. female sex workers report a range of different HIV-related risks that are much higher when they have debt, when they report high levels of residential instability, when they report having more than 3 children. So the idea is that, you know, for example, if they have lots of children, that they're feeling that they have to support those children and take care of them, and sometimes that requires first engaging in sex work and then taking risks associated with doing that in order to make more money to support their children. They're more likely to take HIV-related risks or have other types of HIV-related factors in their practices if they have children with serious health problems. If they report various forms of police abuse, that the police take condoms away from them, which they report police doing. If they report having sex with the police in order to avoid having trouble, or if they report giving bribes to police, or police taking bribes from them. If they report arrests or workplace raids, they're more likely to also face elevated risk for HIV. And if they report physical abuse from their husbands. So see, these are some of the kinds of sort of social vulnerabilities or social related vulnerabilities that become in turn associated with their risk for HIV. In terms of the community mobilization intervention, this is a type of intervention that basically is built on the notion that sex worker risk for HIV is a part of their relations of inequality and their extraordinary marginalization and vulnerability, and that a way to address that is to develop interventions that mobilize them as a collectivity, that build their collective strength, and through that their power to resist different types of abuses and behaviors and so forth. And this is one of the dimension of the intervention that the Gates Foundation has implemented. And we found that the sex workers who report higher levels of collective efficacy, that is the sense that people would help me if I needed help, other sex workers would help me if I needed help, collective identity, a sense of pride that I'm a sex worker, that I'm just doing a job like other people are doing a job, I'm not hurting anyone, or collective action, actually participating in activities to demonstrate their collective strength, you know, going to the Indian government and demanding changes in sex worker regulations and so forth, going to the police and demanding that they respect their rights. Those who report these types of impacts as a result of participation in the community mobilization intervention are also much more likely to be able to use condoms consistently. They are, if they engage with the community mobilization intervention, the more they engage with the intervention, the more likely they are to report consistent condom use. And the intervention, and we've shown that it's related to declines in rates of police abuse. So these are just some of the things that I pulled, some of the key findings. We're less far along on the coercive mobility incarceration study, but some of the things that we're finding so far, a major factor so this is done among all, there's a lot of research that shows that if you are incarcerated, you're at higher risk for HIV, partially because of what happens in the prisons, but largely because of this movement back and forth between the prison and the community that creates an extraordinary amount of instability and disruption in people's lives. So one of the things we've looked at is I think, abhorrent practice of incarcerating juveniles in adult facilities. And we found that among people who report being incarcerated in an adult facility as a juvenile, they also report higher number of lifetime sexual partners, which is an HIV-related risk, ever having paid for sex, a risk, inconsistent condom use, concurrency, which is a form of having multiple partners, sort of not literally simultaneously, but simultaneously in a short period of time, and which also is associated with HIV risk, as well as suspected partner concurrency. We found that if you're incarcerated under 18, regardless of whether in an adult or a juvenile facility, that that is also associated with concurrency. Having a sexual partner with incarceration history is associated with concurrency, and this is particularly important for women in two ways. First of all, in heterosexual partnerships, women who are incarcerated are more likely than men who are incarcerated to have partners with a criminal justice history. And then the women who are the partners of incarcerated men are less likely to have their own history of incarceration, and therefore are affected by some of their HIV-related risks are affected by the fact that they're with a partner who has criminal justice history, even though they do not have one themselves. And the number of incarcerations that somebody has had is associated also with the number of lifetime partners, which is an HIV-related risk. So these are just a few of the critical what we think are some of the key findings from the research projects.
Do you have a preferred order? You all didn't tell us who wants to go in.
Practice it
Alphabetical, there you go. Daniel.
So I noticed that I'm part of a dual minority. I'm the only foreigner on the panel, and also the only faculty member who probably identifies as male. So I've decided to think of Kim Blankenship as Jon Snow. And I hope that's okay. AU's very own Jon Snow. Yeah. So before I start, let me just say that I'm really only one of a growing group of faculty members doing work on global health, and several of them are here. Gay Young is here, fantastic work on Mexico that I benefited from hugely when I did my most recent project on violence in Ciudad Juarez. And Rachel Robinson is here, who works in Africa. Nina Yamanis is here, who also works on HIV in Africa. And there are many others, Jeremy Schiffman, of course, in SBA. And we're an interdisciplinary group. And I think that comes to the fore not only in terms of the disciplines as well as the fields that we represent, but also the issues that we're trying to understand and grapple with. So I want to focus in the next 5 minutes or so on some research questions in my own work that I've been working on when it comes to global public health. And before I go there, however, I just want to point out that this diverse group across campus working on global health specifically has recently engaged in a bit of a consolidation and visioning exercise to kind of see why do we do global health research at AU, and what is it about AU that maybe puts us actually into an advantageous position. We don't have a public health school, we don't have a medical school, so at first sight it doesn't seem that AU that is necessarily well positioned to do research on public health. We actually beg to disagree. We believe that AU has a national comparative advantage in the sense that we can do multidisciplinary critical application of social science theories, concepts, and methods when it comes to global health. So rather than getting bogged down in never-ending conversations with predominantly medical doctors, as much as we appreciate the work, we have a critical mass of social scientists who can interrogate non-medical, non-epidemiological dynamics of health and illness in ways that I think and that we believe actually puts us very much at the cutting edge of that field. We're also very lucky because if we assume for another moment that Professor Blankenship is the Jon Snow, then the Center for Health, Risk and Society really is the handle on the pump that has been pumping out a good number of... Well, that was 150 years ago. I mean, we've learned and we understand much better. So I think, now I really come across that I didn't get the point of the provost speech. But I can assure you, I'll write to him later and I tell him that no, exactly, this is what you said, and I totally got it. But so Chris, we see Chris as kind of an intellectual home for public health research, which crucially we believe includes global health research. And as you've heard from Professor Blankenship, her work is also not necessarily domestic. It also has a very important global dimension in her work on Parivatan in India. And we use Chris basically as a hub to generate additional external grant funding for a whole range of global health projects. Some of the ideas that we're working on at the moment is to organize a symposium to brainstorm with thought leaders in global health on emerging issues in this field. We are also seeking some seed funding to foster student-professor research interaction, and I'm going to talk a little bit about that when I talk about my own research. And ultimately, we're really trying to strive to become a primary research university for both MA and doctoral students in the area of public health, global public health specifically. And of course, I don't want to forget that 4 years ago we didn't have a public health undergraduate program, and now we have one. And last time I asked, we had 199 majors in it. So this is a pretty stellar rise, and so we really try to address global health issues across campus at all levels of the students. So I want to just provide 4 examples of global health research that I've conducted over the past several years. I'm just going to present you the research question, and then I'll talk a little bit about the findings. The first question that I interrogated was, what motivates bilateral, multilateral, as well as non-governmental private donors to back the fight against a particular set of diseases while neglecting other causes of ill health? So is it that these particular diseases that receive a lot of backing from donors, different kinds of donors, are really the major killers? Or is it something else that motivates donors to support the fight against some diseases and not others? The second area that I've done research on is focusing on the private donors. And it's asking whether these new donors, which are extremely important in global health, such as the Hewlett Foundation, Packard Foundation, Ford Foundation, Gates, of course, first and foremost, whether their funding is more responsive to the priorities and the country-specific causes of ill health in the global south than the aid given by traditional donors, such as bilateral donors, USAID, for example, or the World Bank. The third question that I've researched is, what is the primary challenge that global health advocacy coalitions are facing when they're trying to push a new issue onto the global policy agenda, when they're trying to gain visibility for a new issue? And the issue that we interrogated or that we investigated here was aging, because aging very often is an issue that is looked at very much and very, very vividly in the context of rich countries. And there's a presumption that in the global south, aging is not much of a problem because longevity is, of course, very different from highly developed countries, and really morbidity and mortality are structured very differently. So as there's a growing coalition of NGOs, interest groups, as well as some governments that are trying to sensitize policymakers to issues such as aging, what is the main bottleneck? What is the main constraint that they're facing? And then my current project in this area is about trying to understand why it is that there is one particular bilateral donor agency, and that is DFID, which is the British donor agency, that is widely considered to be by far the most influential agenda setter in the area of global health among bilateral donors. Even if we control for different budget sizes, DFID has a fairly large budget compared to most other donors, with of course the exception of the United States, as well as country portfolios. So what is it that really renders one aid organization much more influential when it comes to defining the course of global health cooperation in the future? Very briefly, the findings that I've generated in the research. There now is a growing body of studies that show that global health is determined primarily by both national and organizational interests, and not by the burden of disease. So the biggest killers are not necessarily, and in many cases not at all, the recipients or the causes that receive the highest amounts of funding. It's very much rooted in national foreign policy considerations as well as organizational preferences, which relate to visibility and positioning yourself, for example, as a foundation, as a champion on a particular area. Are the new donors more responsive to recipient country priorities as well as this country-specific drivers of ill health? No, they're not. In fact, in the study that was published in one of the leading development journals 3 years ago, which I conducted together with a student who is now a medical doctor, so I'm not completely we found that traditional donors are actually marginally more responsive to local priorities. So this is priorities. This is not even the causes of ill health, the measurable causes of ill health. This is purely what the people in these countries, based on a Pew survey, 27 countries were included, said what they feel the money for global health should go to. So the performance of global donors from the private sector, first and foremost Bill and Melinda Gates Foundation, is a cause of concern because they focus very much on a few issues that really where they want to make a mark, and they do so at the risk of leaving out a lot of other drivers of ill health. What is the primary challenge when it comes to putting things on the policy agenda? What the study found, which I've also conducted with an AU undergraduate student who then won a Fulbright and is now a PhD student at Boston University, is that they have to navigate very carefully the pros and cons of complexity reduction. So on the one hand, you want to break down a very complicated global health issue like aging and resulting challenges for health systems in a way that policymakers understand, and they've succeeded at doing that. But at the same time, they've decomplexified it so much that there is now a blanket conversation about aging in the global south that does not at all do justice to the massive variation of aging patterns in different countries, let alone regions of the global south. So really, how do you actually change from pushing a simple message to accounting for complexity in order to have effective interventions? And then the project that I'm currently working on, which looks at DFID, the interview research that I've done both in London and here, and with the help of an AU travel grant, so far points to two very important factors. First, that DFID is one of the few funding agencies that still has health experts in each of its country offices. So they source information locally, as opposed to relying on elite level conversations on what is currently going on in Zimbabwe or what is currently going on in Cambodia. And the other one is that very much in contrast to USAID's behavior, DFID is deeply committed, not only in rhetoric but also in practice, to multilateral interventions. So DFID is trying to forge an agenda and then to play a leading role, but always in conjunction and collaboration with others. And that is very different from the single most powerful, in terms of financial leverage, health donor in the world, namely the United States, which has a reputation not only in terms of what they've done in the past, but also when it comes to current policy, to really try to go it alone, because health is part and parcel, according to the US government, of a foreign policy agenda. And that is quite different for the United Kingdom, and certainly for those who care deeply about improving global health, the multilateral approach seems to be the one that we should hopefully see more of. That's what I wanted to share with you. I do particularly want to encourage the students in the room, undergraduates and master students and doctoral students, if there are any, do reach out to the many professors who work on global health across the AU campus. We'd love to work with you collaboratively. It's very rewarding. We sometimes even pay something, but that shouldn't be your primary motivation anyway. So please do get in touch with us. Thank you.
Good afternoon. So I know it's kind of warm in here. So today I'm going to talk about some of my research in food marketing, but I would be remiss if I didn't start by telling you that there's a lot going on in the business school and more related to health. In the business school, we have people who study health-related issues and management strategy, and then IT. In my department, which is one of probably 4 in the country that focuses on public policy issues, pretty much everyone studies some health-related topic. We have people who work at the FDA, people who work at the FTC. My colleague, Christelle Russell, who's in the back, does a lot of really interesting work about alcohol advertising to teens. She develops her own TV shows and designs interventions. So there's a lot of different types of research and approaches to research the intersection of business and public health. But I'm going to talk about research at the intersection of marketing and public health today, and I'm going to focus on my work on food marketing, although I've also done some global health work looking at social marketing in Cuba, looking at tobacco marketing in South Africa, as well as some anthropological work looking at cultural models of low-income Black women and breast cancer, but this is what I'm going to talk about today. So my work at the core is about target marketing. So target marketing is this notion of customizing efforts directed towards particular segments. And I look at that from multiple perspectives. So you can see, starting from the bottom of the box, looking at sort of individual perspectives and issues like, how do people respond to target marketing, and does it vary depending on their social category or the social category of a group that's targeted? Then I started to look more at contextual responses. So how does the dynamics between different groups in society lead people to respond when they are and are not a member of the target market? And I did some work where we found that people who weren't in the target market but saw their brand targeted to other people actually had some influence, which research hadn't thought about at that time. But then I started to look at what are these intended and unintended consequences of marketing and of focusing on one particular group, and that really led me to the health setting. And I also do work on social marketing, which is really about using marketing to create social change, and a lot of that has been focused on health. And so I think about it from all these multiple levels of analysis. So why target marketing and health? And in this perspective, I look at health disparities. So you look at this and you see there's this, sort of grim picture of childhood obesity, and then you see, this, hey, McDonald's, which one looks a little more interesting? Which one would people pay more attention to? So when I started to think about the influence of marketing on health, I thought marketing is a system that's designed to affect consumption, what people buy and what they eat. Food is a major contributor to health. So target marketing structures and constrains people's choices. What you see may depend on, when I talk to my students and they talk about, the TV shows and the ads they've seen, they're very different from the TV shows and the ads that I've seen. And so marketing tends to segregate information as well as products in a lot of sense. So it may predispose minority consumers in particular, thinking about health disparities, to poor dietary quality. And at the same time, like this picture shows, it may limit the effects of general prevention efforts. So it's sort of, does it prevent prevention, was an issue that was of concern to me. So a lot of my work started, and I went and spent time as a Robert Wood Johnson Foundation Health and Society Scholar in the medical school at the University of Pennsylvania. I left my job so I could get some substantive knowledge in health, and I spent 3 years, and this was where I started this work on looking at the marketing environment of African Americans. So this whole notion that target marketing creates different environments and different choice sets and different availability really came from me preparing for my social marketing class at Stanford. I used to teach MBAs, and looking at work on the 5-a-day program. And I thought, encouraging people to eat 5 fruits and vegetables a day is great. It was the largest, well-funded social marketing program from the US government, but what about people who don't have fruits and vegetables in their neighborhoods? And no one had talked about that at that time, and that's really what led me to that program. So I wanted to look at what is this marketing environment, and I've done work to look at it both comprehensively as well as different pieces of it, such as billboards or fast food proximity to schools, and looked at different targets, including ethnic minorities and children. So I'm going to talk about this paper on the context for choice, which we looked at the whole marketing environment and did a systematic literature review of all the research that's been focused on the types of products, the nature of products, the availability, the price, the promotion to African Americans. We did a study over this 14-year period, and we only found 20 articles. which was one thing, that there's such a limited amount of research for the populations that are growing. And I recently completed a similar systematic review on marketing to Latinos, and it pretty much says the same thing as this. So we found that promotion was dominated by low-cost, low-nutrition food products like candy, that there was more attention spent on food, that positive nutritional messages were less likely to appear in media targeted to African Americans, and relative to predominantly white neighborhoods, predominantly black neighborhoods had fewer supermarkets, had a higher density of fast food restaurants, yet fast food was found to cost more, which was interesting. So there's this notion of this captive market in there. So I wanted to link that to the notion of how do consumers respond to these constrained environments. And so that's where a lot of my work has gone more recently, and I'll talk quickly about one project where we were looking at the whole notion of norms. And I don't know if you could see this, it says, when will she have her first French fry? And so the whole idea about the messaging that we have in the environment and how that messaging influences behavior is something I had thought a lot about. And so when I was in the program RWJ and looking at a lot of literature, and everything was about marketing the kids, and I thought, what about marketing the parents? And so this whole notion, the generation of parents were those that were brought up when advertising really became very strong and intense. And so we wanted to look at whether or not fast food marketing to parents influenced what they bought for their kids to buy. And was this driven by norms? Just the whole notion that, Sally feeds her kids fast food, there's nothing wrong with it. Everyone in my neighborhood eats fast food, so there's nothing wrong with it. So we developed a model and we tested it. We used HRSA clinics throughout the country in 6 different locations and collected data from moms who were taking their kids to the doctor. And what we found was that increased exposure to fast food promotion was associated with the belief that it was normative and that their kid ate more fast food. And these social norms towards fast food are what drove this relationship. At the same time, because we had a diverse sample, we also found that it was more the ethnic minority groups who were more likely to see fast food promotion and more likely to have fast food in their neighborhood. So we're starting to get a picture of the ways in which marketing serves as a contextual factor to influence health. As Kim mentioned, it's a social contextual factor that leads to these outcomes even though it's outside of the health domain. And so I'll be happy to take questions or comments. Thank you.
Yeah. Is this your watch? No.
Okay, well, I get the challenge of being last, but nonetheless, I will try to give you as much energy as previously. I guess 3 things that in listening to the previous 3 that I'd like you to keep in mind with my work is that mine is much more local, so you're going to see work here right in DC. It's much more applied, and it's much more focused on chronic conditions. So if you can think about for just a minute your healthcare dollars, or if you want to think about it as the national healthcare dollars, what percentage do you think is spent on chronic conditions? It's about 70%. 70% of our healthcare dollars are spent on chronic conditions. So my work really looks at empowering people to live healthful lives through policies and programs. And as passionate as the others, I am as passionate about working in the field of both merging these 2, policies and programs, to promote healthful living. I do it based on the social ecological model, so perhaps overlap here again with the other presenters, but I like to believe that there's different levels of influence of how we choose foods. So much like we have individual factors, so much of us make a daily choice of eating or exercise based on our knowledge, our skill levels. So educational programs may empower people by going ahead and focusing only on education. But we also have to look at social environments, so the work site, the school systems, our communities. We have to look at these physical settings and also the macro level, which looks at as well policy level. So my work really spans this entire social ecological perspective of looking at how we can influence healthful eating, particularly in schools, throughout education, working with teachers and students, working with community levels, and then policy. So the first place I'll take you is to the District of Columbia's Healthy School Act. So in 2004, we had a national piece of legislation called the WIC Reauthorization and Nutrition Act. It mandated that every school system across the country that took in USDA school food dollars needed to have a wellness policy. Now, remember to think about that chronic conditions have been working its way through through American society probably post World War II. So after World War II, as people became much more affluent, they moved to the suburbs, they relied on cars, we started to see many more signs of chronic condition. So we fast forward now, and in the latter part of the 20th century, we started to see emerging the childhood obesity epidemic. The federal government responded with a policy. Then school districts took it upon themselves to implement their own policies. In the district here, in 2010, DC Council actually implemented the Healthy School Act. And here are the many provisions. And as I sat at the table and looking at this piece of legislation, I urged the Office of the State Superintendent to begin the process of evaluation and have been doing so since then. So not that you'll be tested on these, but essentially what they're attempting to do is to create a healthy environment. They're trying to provide educational opportunities, access to healthier foods, as well as appropriate amounts of physical education and activity for children to be able to do their work and do it well. As you'll get to the last slide, but even our work is emerging even further to look at the concept of cognition and childhood obesity. We know there's a relationship with unhealthy eating and dementia. So now we're starting to look at how does unhealthy eating not only affect from the neck down, but also from the neck up. How is the brain impacted by the types of foods that we eat? So this is just to show you that in order to evaluate this policy, so there are over 200 schools in the Washington, D.C. area. About 60% are DCPS schools and 40 or 45% are public charter schools. All of them are required to fill out a school health profile. So I have composed with the team of folks what we call a composite score. So the composite score gives us a sense of a rating of how schools are doing in implementing the Healthy School Act provisions. And this is one slide that starts to look at the relationship of in elementary schools of math scores in its relationship to the Healthy School Composite Score. So first of all, just a disclaimer, this is not a cause and effect, but what this is starting to show is CAS, which is a comprehensive assessment system that is done annually in schools, shows that there is a relationship between a math score for a child as we increase the healthfulness of the school health environment. So this is only one snapshot. We've done this with math at different grade levels, elementary and middle school, as well as with reading. But this is starting to get the attention of the superintendent, as well as the chancellor, as well as some principals, because the principals are the gatekeepers to their schools. And by showing data such as this, gives us more leverage to be able to get in there and do more programming. because there's a gap right now. There's a policy that's happening, but the educational schools need more resources in order to fully implement the policy. So I've gone before DC Council several times. I work closely with Council Member Mary Shea, who's the author of this piece of legislation, in order to help improve the effectiveness as well as the implementation of this. So moving into then my second area, which is, as I said, the Healthy School Act does a great job in increasing access to healthy foods. So that's a good thing. We would all applaud that every child in DC is served a healthy fruit and vegetable every single day at school. That's a good thing. But as you would guess, just because we put it on their tray does not mean they need to consume it. So our work showed that more food was going in the trash rather than being consumed. And this is one of the reasons that schools have gone from what we call a serve model to an offer model. So that is, they don't even get on the children's plate because schools do not want to see the type of waste that we do witness in DC schools. So up in Cornell, there's a group called the Behavioral Economics Research Center, and USDA has funded them, and they have funded us for the past 4 years to be able to look at behavioral economic strategies to increase the consumption of healthful foods. So it's a perfect marriage between we have a policy, we've increased the access, now we have to bring the children along and engage them in order to consume the types of foods that we're hoping will help them with managing, not only the learning that's going on, but their own life. So on the bottom, and I glossed over this, broccoli we had the best success. So at the beginning, as you can see, we have experimental and control schools. Sonya would be happy to know that we are in Ward 7, which is has a lot of health disparities in Ward 7, so we don't go to Horace Mann across the street. It would be far easier for us to do that. But our group of students go down to Ward 7. We have 4 elementary schools, 2 control and 2 experimental. And as you can see, by engaging them in a taste test, so actually, much to Rebecca Basu's work, we were able to get this story on WAMU, but essentially we give the children 3 options of how they would like their broccoli prepared. And the children vote on which preparation method they like, and then it's served that way the next time it's on the menu. And as you can see with the blue bars, our follow-ups show that consumption really goes up significantly. So we're really pleased with the results. It's a low cost, it's a feasible option, and that's the goal of what USDA ERS would like to see us do, is these feasible things, because translating research into practice is a key piece to what we need to be doing. So to just give you a sense of what my work is for this upcoming year, so I'm 2 more years funded by Kaiser for my school health policy evaluation. I've just been given another $100,000 to look at behavioral economic strategies. We'll be looking at Arlington school systems as possibly Alexandria. They have a serve model or an offer model, which makes it much more difficult. We also have an evaluation to a DC Farm to School program that I have not mentioned. We have submitted about a month ago Healthy Smart Kids. This was to look at student level evaluation of the school health policy. So we should hear any day, so send me good vibes about whether that evaluation will be funded. We're working with the Center of Behavioral Neuroscience to look at cognition and obesity on October 13th and 14th. We do have a cognition and childhood obesity symposium, so please check that out. And lastly, expanding beyond schools is I'm working very closely with Unity Healthcare System. There's 10 clinics around the city. They provide they have 105,000 members, 70% are Medicaid. And in the past 6 months, we have worked on developing a concept paper on what does health promotion interventions look like for a widespread or a citywide healthcare system in the United States. So that's really exciting and emerging work. But if you go back to the social ecological model, we really need to touch people in many different places along those levels in order to reach people not only at their homes, in their communities, at their workplaces, in schools, perhaps where they access health care. So many different places. So I don't do this work alone, so those are some of my many thanks to some of my collaborators as well as the students. Thank you very much.
Kim, I believe you were going to moderate the discussion in the Q&A period.
Okay. Do you have any questions?
I'd like to tell the caterer here at AU how I like my broccoli to be. I have a feeling it's going to be good for me.
How sustainable is the broccoli program in terms of time?
Actually, the food service we've worked with is minutes. They set it up, the students like it, the food service, they can go through about 300 children within a day at the end of their lunch period. So it really is very sustainable and feasible, which is cost-wise.
The consumption over time.
Oh, consumption, we do 2 post-baseline, and it does maintain, so it's about 3 weeks apart. So 6 weeks out, the second time offered, even 6 weeks out from its introduction, it's still being consumed. So perhaps a longer term would be.
I would like to make an announcement too, to make sure while people are still here, there's a joint seminar that's happening between CHRS and the Center for Business in the Capitol in Kogod, which is happening on October 15th, and it's called Corporations and Protecting Public Health. And we'll have Dr. Nicholas Freudenberg, who will speak, and he has written a new book called Lethal But Legal: Corporations, Consumption, and Protecting Public Health. And that will be held in Kogod from 2:30 to 4 o'clock on Wednesday, October 15th in the Kogod Student Lounge. So you may be interested in that as well.
I have a question for Sonia, and I think one of your slides touched on this. Of course, there's this huge tension in marketing between sort of what a good government policy can do up against the massive dollars of a mega multinational corporation. So if costs were no objective, or no problem, what would be the most effective government social marketing program in terms of improving the health of Americans?
I would say balancing the messages that people receive. If you said cost with no effort, because that would cost tons. Because if you think about it, everything, so many norms are embedded into our society. If you break up with somebody, you should eat a gallon of Haagen-Dazs. If everything has food attached to it, and there are certain things and norms that are really integrated into our lives. A lot of my work has been funded by the Robert Wood Johnson Foundation, and they focused on childhood obesity for the last 10 years. And they've recently moved and changed all their funding priorities to focus on a culture of health. In recognition that it's not just, the ads for fast food restaurants. It's not just these individual variables, but like just Stacy said, throughout the ecological model, we get messages, a lot of messages from marketing that tell us how to live, how to be, how to eat, how to be active, that don't support living a healthy lifestyle. So balancing out those messages, I would say.
Hi, I do tobacco research, and I have a question for Sonia. Sorry, and I know this is unfair because you're talking about your work with food, but I just want to throw it out there because I do have to leave. That I just submitted a grant to NIDA to look at the effects of menthol cigarette smoking on individuals, because the FDA is considering banning menthol in cigarettes because they're seeing these associations with more difficulty quitting, with greater dependence, and so forth. But the issue here is that it's highly overlapping with race. And so the grant we submitted, I did it with my collaborators at the Schroeder Institute, which is part of the American Legacy Foundation, which has done a lot of marketing and advertising for smoking. We've sort of ignored this, not ignored, but we haven't attended to the issue of the differential marketing of menthol to African Americans. We're simply saying, because we're in DC and we have access to both, equal numbers of blacks and whites, we will simply now test this in a more empirical way to look at causal relationships. But the reason I wanted to just throw this out at you is when you were talking about what you do, I was thinking, wow, wouldn't it be nice, though, to have some sense of how this marketing may be the causal reason why African Americans smoke menthol more so than whites, even though internal documents from tobacco companies suggest it's more than marketing. So anyway, I know it's unfair to throw this.
There's actually a couple of papers that do try to draw the causal links between menthol and tobacco marketing that do use the tobacco document. So I can certainly send you those citations. And it does seem like it has to be considered because it is such a big part of it. A lot of the discussions and policy discussions that have gone on in terms of menthol and regulating menthol have been around race. So that almost has to be a component of your grant. It sounds like, and if you can shed light on that, that would be really helpful.
Well, yeah, I think you have a chicken egg issue, right? Because, well, why is it that these companies are marketing to these populations? You know, so does it end up becoming a bidirectional, thing, not just a unidirectional? So I just wonder what your thoughts on that are. Or does it not matter? It simply doesn't help the situation, so therefore.
Yeah, I think it's the same issue in food. And one of the things we looked at is, if you think about, does marketing have an impact on people in general in terms of the food they consume? So is there a differential impact in populations where we see disparities? And so starting from that baseline, being able to show some type of differential impact would drive you that much further, even though the chicken and egg issue is always going to be there because there's marketing everywhere. Although when I did work in Cuba, that was a part of it because there isn't any marketing there. So I was able to look at a context where there isn't any type of commercial marketing. But here, you're always going to have that chicken and egg problem, so you just have to get creative on the types of evidence that you use to support the theories.
Yeah, well, we're trying to disentangle it. So we're just trying to say, okay, let's just have equal numbers of menthol and non-menthol blacks and whites, and then see how they react and so forth. I still may be contacting you. Thanks.
Questions?
So I got a similar question for Dan. So you said that one of the problems thinking about aging in developing contexts is that they end up having to oversimplify of aging in global south and be like it's all the same, right? So what would be your recommendation for how to go about that? I mean, what would we learn from your research that, to some extent you're looking at constraints, and so those are constraining conditions, but how do you change that?
What we found in the research is that these advocacy coalitions actually try to sensitize policymakers, particularly within the United Nations system, with accurate information, just very selectively, but accurate information. And then that got kind of mangled in the global governance policy formulation. And rather than treating selective and accurate information as illustrative, it was ironed out and said, this is the, so let's say, for example, they use a lot of data from Argentina, which has an aging society. And so they said, here is a good case for Latin America, right? Which you can't say at all, right? Because this, the situation in Bolivia and Ecuador is completely different from the situation in Argentina and Brazil, or Uruguay, right? So the key challenge here is to almost, we've had one interaction with 2 NGOs who were part of that coalition, where we said, you almost have to put disclaimers on the data you're using and saying, if you present this data, then you can only do that for that context. Otherwise, you have to provide a very nuanced image. The problem really is that the way that the research shed light on it is that, of course, the United Nations sees itself as an agency that pushes global solutions for global problems. And the more you say, well, this is a very nuanced issue, and you really have to make sure that you don't throw Pakistan and Bangladesh into the Indian basket, the more stares you get. They say, but is it a global issue or is it not a global issue? Yes, it's a global issue, but it has a lot of variation within that issue, right? But that doesn't mean that it doesn't matter. Because if you have a country like India or a country like Indonesia, which over time is actually getting older, we're talking about millions of people. but it doesn't allow you for some kind of global aging framework. And the problem really is that, and I would actually say that is a more general issue in the area of global public health, is that global public health is often understood as health issues that affect people globally. And that's, I think, a problematic conceptualization of global health. Global health means understanding the different drivers of ill health and the different measures, and to compare them across regions, not about one issue that affects us all, right? So we tend to kind of focus on the thing that affects us all. Ebola is a case in point, right? Ebola now arrived in Dallas, and suddenly it's a global health issue. It doesn't have to be a global health issue, because thousands of people have already died in a sub-region in Africa, right? So as global health researchers, I think we should, and we're actually meeting next week to come up with an idea for an NSF Rapid Grant, hopefully. We should address health issues where they happen in the world, and not kind of wait, let alone frame them as something that is a global time bomb.
This is more of a general question. I don't know if anyone has an answer to this. But moving forward in public health research, for many, many years, race has been used as a characteristic in lots of public health research. And the more we look into that, race is a lived reality, but it's not a biological characteristic. And how do you see race playing a factor in studies moving forward in public health? Or maybe in school, obesity programs, race is often used as a factor, but is race being substituted for socioeconomic status or some other characteristic that it's being hidden because we just keep saying race?
Well, in the work that I do, we look at a lot more variables than race, right? I mean, certainly in the populations that I'm serving and working with in Ward 7, 99% of the children that I see are African American, but that is not, I mean, there's health disparities in that community, not because they're African American, it's because there are high poverty rates, there's high crime rates, and there's the access issues and safety issues there. But I don't think we can ignore race, but I don't think it is, like you say, a predisposing factor. It is a factor, but it's the entire community that we have to, and that's, I think, what the social ecological model reminds us of, is there are personal factors, right? Knowledge and skills and education, but we have to use all of the tools in order to address, and once again, to address health disparities as well as educational disparities, which in the world that I live in within SEP, education and health go hand in hand. And they do across the world, except not in the US, where we separate them out. So here we try to address both of those social issues. I don't know if you want to.
Yeah, I would think that we have to think about what is it that goes with race that is important for that particular health behavior. So I think about highlight Mike Bader, some of his work that looks at neighborhoods and identifies the characteristics of neighborhoods, that it's not because the neighborhood is black, but the black neighborhoods happen to have fewer healthy options in those neighborhoods. So I don't think you can go around it and not talk about it. I do a case in my class that's about obesity among ethnic minorities, and the students find it hard to talk about race because they think we should sort of be beyond it and not think about it. And the case says specifically, it has huge color charts that show that it's only among whites that obesity declines with higher income and higher education. So among Latinos and African Americans, higher education and income does not protect you from obesity rates. In fact, the highest rates of obesity are among higher income African American girls and higher income African American women. So that tells you there's some other things that are going on. But still people say, well, it's because of the poor people. And so, sort of getting these nuanced ideas into the way we think and talk about these things are really important. So I don't think we can go, it would be nice if we could not talk about race, but I don't think we can get around race. We have to go through it and figure out ways to deal with these issues, understand the complexities and the nuances of them in order to get around it.
Yeah, I mean, for me, this is something I am completely struggling with in the race disparities incarceration project. And I think biological race isn't particularly meaningful for health, but socially there is definitely, and the challenge for me is that, people talk about, take out neighborhood or take out class or take out these, take out incarceration or take out, and you'll explain away all these things. But I think all those things we're taking out also include race. So I feel like it's really difficult to figure out methodologically, like how, at least in quantitative data, how to capture all of the ways that race infuse. It's not really about saying control for sex, control for, because race is so embedded in many of those things as a social factor that I sort of struggle with. And for me, you can kind of make the argument with qualitative data. Sometimes you can find it, or you can kind of triangulate different data. But I think it's an incredibly important question, but really difficult to figure out how to demonstrate to people when they say, oh, you're just control for this or control for that. And all those thises and that's, a lot of them, really, race is really embedded in them too.
But I think that's why we're encouraging a multidisciplinary inquiry. I mean, one of the concepts that are evolving is the notion of cumulative advantage and cumulative disadvantage that is from these multi-factors. And so when you look at life course and you start looking at the different interactions you have and then the consequences of them, these are newer theories, sociological theory, that is coming out that is a broader sweep. And unfortunately, the social sciences are broken down into a range of disciplines: psychology, sociology, anthropology, economics. Yet when we're talking about social phenomena and the interaction of human beings, there is a gestalt that interacts across these different areas. And science as a field has spent more time looking at the question. In the social sciences, we have these categories. And hopefully in this institution, what you're seeing here is an effort to dive deeper into questions and to look at the question rather than the disciplinary approach to the question. And I think that will lend itself broader insights to social phenomena and individual behavior.
I'd like to take the Provost's last idea about looking at the questions, not looking at methodologies or testing an answer, and ask you all to step back in time. You sit here now as professors, and you have a bunch of students sitting here in the class. Put yourselves back in time as students, and if you had just heard your talks, what kind of research would you have been challenged to do as a student? Because you have a bunch of students here vitally interested in these topics, studying these topics, and probably wondering, what can I do as a freshman, as a junior, that might be interesting research in your respective fields?
Join my research project.
Straightforward, and of course not exclusive, but in global health, what can we do to infuse a much more nuanced understanding of social, cultural, socio-economic processes in health interventions? And how can we go beyond a medicalized approach to global health? How can we stop airlifting mosquito nets into Africa and expecting to get a Nobel Prize for it? How can we contextualize health interventions? So no matter what your field is, even if you're a chemistry major, and again, I have nothing against medical students, or against chemistry majors, you know from your daily experiences that social interactions probably matter most in terms of defining who you are, not the genetic material that's in you, right? That's no different for people in Thailand or in Namibia or in Timor-Leste. What does it actually mean for going about improving health in these spaces? think that is a broad research area that I hope that together with the faculty we can push here.
Yeah, I mean, just to pick up on that, I think a social, an agenda that understands the social dimensions of health is really important. It's really important right now, I think, because there's such a push towards biomedical approaches to health, and there's sort of this notion that, we'll develop the perfect health intervention, in a laboratory, or, the perfect technology or whatever, and then we'll implement it and use social, and then it doesn't work, and then you social scientists are supposed to come along and kind of help us figure out and convince people they should use it. But we're not responsible for developing it with any knowledge of how people live and how people, what their daily challenges are and what their, what kinds of relationships they live in, what's possible within a relationship or what's possible within their urban environments or whatever. So, and now while funding for research, especially, probably everywhere, but I'm most acquainted with it in the field of health, is really, really under, is being cut so extensively. That the focus is going to be on biomedical approaches even more, and it's going to be more important to keep that voice of the social sciences strong. I am right now on a NIH review panel that's reviewing in the context of AIDS. Our question that we have to answer within the next 2 months is, what's AIDS-related research? And we have to go through 7,000 projects that have been targeted as not AIDS-related research. And a lot of those projects are social science, and it's sort of like, oh, well, that's about, housing vulnerability or something. That's not about AIDS, or that's, and basic research in general is having problems, but I'm really worried about where social sciences research is going to be in this environment where things are getting cut and people are looking at, well, what does that really have to do with health? And it's kind of it has an extraordinary amount to do with health, but it also is much harder to convince people, that it's immediate and necessary.
I would follow up with everything that was said and agree, and think that there's a way to use my classes as a student and use DC as a laboratory in order to explore a lot of these issues. I mean, I think there's often we think that we have to go someplace else, or that we have to look really far away, and DC reflects so many of the differences, so many of the global issues that we've seen, so much health disparities. My students are working with the SNAP Ed program in Ward 7 and 8 to try to market increased physical activity among kids there. And so that's an opportunity where they actually get to get out into the community, to understand what's going on, to think about issues of race and income and neighborhood disadvantage and those types of issues that, you can easily stay on this campus and never get off and see those things. And I know lots of students don't. My students worked with Petworth last year. People are going, where's Petworth again? And, and it's like 20 minutes on the metro. But take the opportunity to explore some of these ideas, and I think we've all brought up ideas from very different perspectives, and look at, think about what interests you and how that relates to health, because I tend to think everything relates to health. And there's probably some angle that you can take on it.
Yeah, I would echo. I would say spend some time in another neighborhood that pushes you outside your comfort zone. You don't need a research project. Just go and take a walk through the streets and look at, absorb what you're seeing. And I guess I would then say also a plug for the Affordable Care Act. The Affordable Care Act is really trying to shift us away from the biomedical approach, understanding that 70% of our healthcare dollars are spent on chronic disease. Chronic disease we have done a lot of advances with biomedical treatment of heart disease and certain types of cancers, but we've done very little with behavioral aspect. And the Affordable Care Act is like putting communities and prevention to work together. So sometimes what you'll find are people who are in urban planning will be your best friends, right? These are kinds of new, so think outside the box. think outside the box when you're thinking about interventions. They're not the typical ones, which echoes the multidisciplinary approach. We are not going to find these answers easily, but that doesn't mean we have to keep trying, because it impacts people's lives, it impacts their educational aspirations, it impacts their income. So we all feel so passionate because we know we can make a difference in everyone's lives by improving not only individual but public health. Everybody's life becomes raised as a result of it.